Good evening. Thank you for coming out to our 5th annual symposium. On behalf of Zicharon, the organization that provides continuous support for people with dementia and Alzheimer's, who understands the needs of the patients and the elderly in our community. We wanted to thank the two speakers that we have here tonight for giving up of their valuable time and who are going to be here and give us some of their guidance. Dr. Greenberg will be the first speaker. He is a devoted doctor to his patients. He's the chief of geriatric psychology in NYU Lutheran Hospital. Dr. Greenberg.
Okay, thank you very much. And do I have a clicker for the slides? I do now. And is there a way I can get the laptop here so I can see? Because otherwise, a little hard to see from here. You think that will reach or not reach? Okay, well, let's see if I can, just so I know what I'm looking at and what I'm talking about. Okay, well, let's see. Anyway, I'm Dr. Greenberg. I think I have met a number of the people and families here. I was talking ahead of time, and I want to thank Zicharon and Leah Horowitz and her colleagues for inviting me. I think she does tremendous work. It's a great organization, and we've been very happy to get referrals from her and to do whatever we can to be of help. Now, I know many of you here have loved ones who have dementia, Alzheimer's or other dementias, so I'm talking to a knowledgeable audience. But I still think there's a lot of confusion about what are some of the differences between different kinds of memory difficulty, normal memory changes, mild cognitive impairment, Alzheimer's disease, other forms of dementia. So I wanted to take a few minutes to give a little background and really kind of go over what some of these distinctions are. Okay, this is simply my title and my position, and I just have to ask, I can neither see from here nor the screen over there from this angle. Is there any way that we can get the laptop up here? If not, I can I have another alternative. I can take mine, and I can, if you just give me 1 second, I'm going to get it in sync, and I'll be able to see the same thing. So, okay, and did I do something to, okay, pardon the technical difficulties here, but we'll get this worked out. Okay, so let's see where we are. Okay, so here we are. I think we're finally in sync. So let me talk a little bit about memory disorders in general and the different categories. There's something called age-associated memory impairment, and this is not a disorder. These are the normal changes that happen with age that you and I and everyone who is lucky enough to get older will experience. And it involves things that we've all noticed, a little bit of slowing up, the tip of the tongue phenomena where you know what you want to say, you can't quite find the word. You may need a little cue or hint, but you eventually get it. And these are just normal physiologic changes that happen with age. There's another condition called mild cognitive impairment, or MCI, in the DSM nomenclature, which is the psychiatric terminology. It's now given a fancy term of mild neurocognitive disorder. And this is kind of an intermediate condition. For some, it's a stepping stone on the way to a more serious dementia like Alzheimer's disease. For others, it's simply a static condition where people may stay with these mild changes and not progress. And then finally, we have the category of dementia, which in, again, the DSM or the psychiatric nomenclature is now called a major neurocognitive disorder. Is that changing? Yeah. Okay, so let me start with MCI, and this is an important condition that's got a lot of attention recently. An MCI, or mild cognitive impairment, refers to cognitive deficits where there is a decline from a prior baseline. If you could never do certain things, if you had developmental problems as a child, that's not what we're talking about. It's people who had achieved a relatively normal cognition and then have some change, usually age associated. And again, this is an intermediate condition between normal aging and dementia. It's basically a clinical diagnosis, but there are guidelines. If you do cognitive testing, these people will generally perform about 1 to 2 standard deviations below the average or the mean. This is simply a statistical term, meaning they're in the bottom 3rd to 16th percentile. But the important point is that there is not yet any major functional impairment. They're still able to carry out their activities of daily living without any real problem. And there are a couple subtypes of this. There's amnestic MCI, which involves mostly short-term memory, non-amnestic, which involves other thinking abilities such as organizing, planning, higher reasoning, abstract thinking, and then mixed, which may include a combination of these things. It's fairly common. It occurs in about 10 to 20% of people who are over 65. But the important thing to take away is that there's a fairly high conversion rate, meaning people with MCI, some will simply stay that way, but each year about 5 to 15% of people with this condition will move on and develop an actual dementia. So it's kind of an early warning sign and something we need to pay attention to and track carefully. And then let me get to dementia. Again, you've all heard this term. It is not a diagnosis, but it refers to a group of syndromes. And the definition is a decline in cognitive ability from a previous higher level, like we said before. These people usually have more severe impairment. They'd be in the 3rd percentile or below if you do cognitive testing. And they have impairment not only in memory, which is usually the earliest change, but at least one other cognitive domain that may involve, again, judgment, reasoning, ability to plan and to organize. And again, importantly, it's at a severity where the cognitive and behavioral changes are significantly interfering with their independence and their daily functioning. Now, many things can cause dementia, but by far the most common is Alzheimer's disease. And Alzheimer's disease is a particular degenerative disorder of the brain. The hallmark, and I don't want to get too technical here, but if you look at the pathology, if you look at the brains of people with Alzheimer's, you see 2 main things. You see amyloid plaques, which are made of an abnormal protein that accumulates between the nerve cells. And then within the cells, you see what's called neurofibrillary tangles. These are another abnormal protein that are associated with the cell's architecture, their kind of support system. And abnormal forms of these proteins form tangles. They change how the cells function, how they communicate, and ultimately cause cell death. So this is Alzheimer's disease, and it accounts for about 50 to 60% of all causes of dementia. There are a couple of variants of this. One is called frontotemporal dementia. This accounts for maybe 10% of all forms of dementia. This often has an earlier onset. People often develop it in their 50s or early 60s. And instead of presenting with memory difficulty, often they first show problems in behavior. They may become disinhibited. They may lose normal social graces and norms. They become rude, self-centered, inappropriate behavior. Other patients may develop early language problems, and there are rare types where they develop movement or motor problems. The next most common category is called vascular dementia. It used to be called multi-infarct because it's often characterized by multiple strokes in the brain. and these involve either accumulated multiple strokes or infarcts in the brain, or fewer strokes but in key important areas of the brain. There's another form called microvascular disease, which we're finding more commonly, where people have changes in the small blood vessels that feed the connecting fibers in the brain, and these simply accumulate over time. There's not a single event. It's usually silent, but it essentially disconnects parts of the brain from each other, and this can also cause a vascular dementia. Now, Alzheimer's and vascular dementia often occur together. One doesn't prevent you from getting the other, and in fact, one may be a risk factor for the other, so we often see a mixture of the Alzheimer's and the vascular dementia. And then thirdly, there's a condition called dementia with Lewy bodies, which is a Parkinson-related condition, often presenting early on with hallucinations, periods of acute confusion that have no explanation, and they often have motor symptoms that look like Parkinson's disease. And this is an often under-recognized form of dementia, but it actually is the third most common type of dementia. And then there are many other more rare forms of dementia. Okay, to see if I'm on the same slide here. Yeah. Okay. So about 5 to 8% of all adults over 65 will have dementia. Age is the main risk factor, especially for Alzheimer's, and rates rise with age, approximately doubling every 5 years over 65. So by the time we reach 85, about 25 to 50% of the entire population will have changes of beginning Alzheimer's disease. So that's a pretty sobering number, that all of us who are lucky enough to get over 85, there'll be a 40-50% chance of developing dementia. I guess that's the price we pay for getting older. Worldwide, about 44 million people now have dementia. This will double by 2030 because of the aging of the population, and will triple by 2050. So it's really becoming an epidemic. Let's see, here we go. So let me talk about the risk factors for dementia, and I want to start with genetics. Now, many people when they come see me will say, oh, my mother had dementia, my father, my Aunt Tilly had dementia, am I at risk? And the good news is that it is extremely unusual to have a genetic form of dementia. The vast majority are idiopathic, they just occur with age. So unless you have a particular family history of especially early onset dementia, having a family member with dementia is rarely a risk factor for you. So you don't need to worry about that. Having said that, I'll just mention like fewer than 1 in 1,000 for early onset dementia, meaning before your 60s. There are a couple mutations, and again, I don't want to get too technical, but there are proteins and genes called presenilin that are on chromosomes 14 and 1, where mutations may cause an early onset dementia with an autosomal dominant pattern, meaning there's often a strong family history, and if you have one gene, you're likely to get the dementia. Another one called the amyloid precursor protein on chromosome 21. This is the chromosome that's in 3 copies in Down syndrome, and virtually all patients with Down syndrome will develop Alzheimer's type changes, probably because they're making too much amyloid from this abnormal gene. For late onset dementia, again, the main risk is age for Alzheimer's disease. There is one gene found in fairly recent years called apolipoprotein. It's a fat-carrying protein that has other functions in the brain and in the body. But we found that if you have a particular form of this called E4, it increases your risk of dementia. One copy gives you about a 4-fold risk of dementia. We see this in 25% of the population. 2 copies of this E4 gene will give you a 10-fold risk of dementia. Doesn't mean you're going to get it, but it means you're more likely to get it, and perhaps at an earlier age. If you have the E2 form, that's mildly protective. And there's some evidence that it may affect more the age of onset and cause dementia earlier rather than the ultimate risk for it. For vascular dementia, there is a rare variant called CADASIL, which is an autosomal dominant gene mutation that will cause multiple small infarcts at early ages. But again, these are very rare conditions. I'm only mentioning them because they do have a genetic basis. But remember, the vast majority have nothing to do with genes. And I think I mentioned before, the frontotemporal variant of Alzheimer's often has a family history. About 1/3 of them will. And there's a small number, about 10 to 15%, where a single gene, an abnormality in what's called the tau gene, will cause a frontotemporal dementia. So these are kind of the rare forms that you don't need to worry about, but it's worth mentioning. Now, the main risk factors for dementia I have here, and these are all causes of dementia. The first one, older age, I'm afraid we can't do much about. The only cure for that is dying early, and that's usually not a good alternative. But if you notice, many of the other risk factors are modifiable and are potentially treatable or helpable. So hypertension, diabetes and obesity, smoking, high cholesterol or other lipids, triglycerides, cardiovascular disease, stroke, head trauma, low physical and mental activity, low education, depression, post-traumatic stress disorder, which I'll talk about in a minute, substance abuse, and some recent data on sleep apnea. These are all conditions that may bring on dementia earlier, and many of these we can do something about. So that's the good news, is that it's not a hopeless factor. And don't forget, all we have to do is delay the onset by a few years, because if it begins in the late 80s or mid-80s, people will often die before things progress, and all we have to do is delay onset by 5 years, and we've done a lot to prevent dementia. So prevention, and this is related to the last slide. As I mentioned, about 20% of people have this intermediate condition called mild cognitive impairment if they're over 65. And we said about 10 to 15% of these each year will go on to develop a dementia. So over 3 years, about half the people with mild cognitive impairment will develop a dementia. And this is compared to only 3% if you match people for age, but they don't have mild cognitive impairment as a starting point. And there was a recent study published that said, well, what can we do? What can we modify to help prevent this change from the mild impairment on to dementia? And just to summarize here, the most important things were preventing diabetes or even prediabetes, so keeping your blood sugar within a normal range is very important. There's something called a metabolic syndrome, which is a combination of factors that involve abdominal obesity, fat around the stomach, increased bad cholesterol and triglycerides, high blood sugar, and hypertension. And if you have 3 of these, that's called a metabolic syndrome, and that is a risk for developing dementia. So going to your family doctor and helping to modify these factors can be very important. And interestingly, there were dietary factors. People on the Mediterranean diet, with fish and olive oil and tomatoes and grains, had a lower risk than people on other types of diets. And people who had low levels of the B vitamin folic acid had a more frequent onset of dementia. So eating leafy vegetables, spinach, or taking folic acid supplements if needed can be a helpful factor. Now, I promised Leah that I would mention something about Holocaust survivors and dementia, and initially I wasn't sure there was much literature, but there really is some important data here that I think is worth mentioning. Now, it's been found for some time now that people who develop a post-traumatic stress disorder, and I don't want to spend too much time on this, but I think you're most familiar with that term, that people who have PTSD have a higher rate of age-related medical disorders, including dementia, as well as all-cause mortality. Veterans who have PTSD had nearly a 2 times higher rate of developing dementia of all causes over a 7-year follow-up compared to veterans without PTSD, and this was controlling for all other variables like having traumatic brain injury or alcohol abuse or other psychiatric disorders. And there's also evidence from some Israeli researchers that Holocaust survivors and trauma victims who developed PTSD really showed evidence of accelerated brain aging. They had significantly more deficits in learning and memory than age-matched controls who did not have traumatic events like going through the Holocaust or other forms of PTSD. So we're now learning that it's not just an emotional disorder, but it has major consequences both for physical health and for brain health. Now, the causes why this should be are not completely clear. Some may involve chronic elevation of stress hormones like the glucocorticoids, and we know that elevated cortisol is toxic to the brain. It's been associated with atrophy or thinning of key parts of the brain involved in memory, like the hippocampus. Chronic stress will lead to increase in inflammatory markers, and increased inflammation is associated with atherosclerosis or hardening of the arteries in the heart and the brain, and that can go on to produce dementia. Holocaust survivors, of course, had periods of severe malnutrition, infections, both involving the nervous system and others, so these may all be factors. The other important point, and I think many of you here may have seen this, is that Holocaust survivors who develop dementia may often imbue current interactions with the negative emotions and memories of the Holocaust and re-experience traumatic events with fairly minor provocation. And that may be one reason why we'll see things like a well-meaning caretaker who might be a little bit rough and grab on and try to get them to take a shower. They may re-experience memories of being taken by Nazi guards to the showers or the gas chambers, and that evokes a dramatic event. They don't have the cognitive ability to make those distinctions, and that's often something that we see in these patients. Okay, let me go on to what kind of evaluation we do for dementia. Careful history is crucial. A physical exam and mental status exam. This can be just a clinical one, or we have various rating scales that can be used. In early stages, neuropsychological testing, which is more detailed testing that looks at different cognitive abilities that are normed for age and education background, can give you very important evidence about the pattern, the nature, and the severity of the cognitive deficits. And in terms of laboratory studies, typically the purpose here is really to rule out things that it may make the patient worse than they need to be. Very rarely we'll find a condition that is the primary cause of the cognitive impairment. Very low levels of B12 can cause nerve degeneration. Underactive thyroid can produce a syndrome that looks like dementia. But usually these are conditions that simply cause what we refer to as excess disability. So they may have a dementia from other causes, but if they have one of these other superimposed conditions, it makes the functioning worse than it needs to be, and we can treat these and improve their cognitive function. Rarely a latent infection in the brain, from old syphilis or Lyme disease can produce a dementia syndrome, so these are things that we will sometimes look for. Let me just mention brain imaging, the MRI and the CAT scan. I think it's a very common misconception that we can diagnose dementia based on brain scans. We can't. They are sometimes, but often not very helpful in diagnosing the dementia. We do them for several reasons. Number one, in early stages, with atypical presentations, we'll sometimes find something very unexpected, like a large tumor growing in the front of the brain without other symptoms, and that's just found as a surprise on a brain image. We may find a silent stroke or strokes that we didn't know about, but otherwise they aren't usually very helpful. You can see a lot of atrophy or thinning of the brain and have normal cognition, or you can have a normal-looking brain and have terrible cognition. So they really don't diagnose anything with rare exception. They simply give confirmatory evidence and can help rule out certain other causes. But at some point, especially early on, most people should have a brain imaging study just for these other purposes to look for unexpected findings. We now have fancier studies like functional imaging, PET scan, which stands for positron emission tomography. These are not really needed in routine cases. They show the metabolic activity of the brain. in unusual, atypical cases, or when you suspect the condition we called frontotemporal dementia, they can provide confirmatory evidence, but it is unusual and we don't normally need to do these kinds of studies. We now have the ability to actually image that abnormal amyloid protein in living brain, which we did not have before. There's something called PET studies using florbetapir or amyvid, which binds to the amyloid, and we can image that. But again, it is not a routine diagnostic test. In young patients who are having unusual symptoms, early onset of unexpected memory trouble, it may be helpful. The point here is that if you have a negative test, if you don't find the amyloid, that is not consistent with an Alzheimer's diagnosis. So you can pretty much rule out Alzheimer's if you have a negative test. If you have a positive test, though, other things can produce amyloid in the brain, and it is not diagnostic of an Alzheimer's disease. Other studies like electroencephalogram or EEG, spinal tap, are only done in very rare circumstances where you expect certain infections or seizure disorder, etc. Ultimately, early detection is the holy grail. We now know that before a patient develops symptoms of Alzheimer's disease, the process has been going on for decades, not just years, but decades. So the hope is that if we can find this condition early on or find markers that it may be developing, we may be able to intervene early. We can't yet, but we're moving in that direction. But the key is to find markers that show people at risk early on, long before they have any symptoms of the disease. We can't really do that yet clinically, but I just mentioned here a few. Am I on the right page here? Yeah. No, I think I'm actually behind my slides, I think. Let's see. I'm sorry. I don't know why this isn't changing the slide here. Is there some? Can we go back or we go forward one? There we go. Okay. That's the one I'm actually talking about. So we talked about this apolipoprotein. If people have the E4 type, they may be at risk. If you see on an MRI the atrophy of a particular brain region involved in memory, the hippocampus, functional MRI or PET scans can show abnormal connections in the brain and abnormal activation with certain cognitive tasks. And finally, there's certain markers that we can find in spinal fluid that may show people at risk. And we're developing markers in the serum that you can do from a blood test. But these are research tools, and we are still a ways away from being able to use these clinically. Okay, that worked. So let me move on to treatment. And first, a few general principles. A thorough diagnostic evaluation is crucial. You can't just say, oh, my mother is having memory trouble, what can we do? You really want to try to refine the diagnosis and get a sense of what's going on, because the treatment approaches may vary. You always want to assess for reversible or treatable causes that we had talked about before, the excess disability. For all patients, you want to optimize their medical status, their blood pressure, their cholesterol, glucose. Look at their medications, which we'll talk about. Make sure their vision and hearing are as good as they can be, because sensory deprivation can worsen confusion. If they need a hearing aid or glasses, make sure that's done. Check their diet and their nutrition. You want to optimize the environment. They have to have a safe environment, adequate support with their activities of daily living, nutritional support, social and legal help if needed. Physical and cognitive exercises are key, and I can't emphasize this too much, especially early on. It's the old use it or lose it motto, and we have a lot of data that physical exercise and cognitive exercise, using memory, using thinking abilities, probably work at least as well, if not better, than any medication we have. So going to a day program, being involved socially, There's a website called lumosity.com that if you have computers you can go to, and they have memory exercises and activities. So repeat it, Lumosity, LUMOSITY.com. And as all of you know who are taking care of these patients, you need support and you need services and education so you don't burn out, and to help you deal with what's a very, very difficult situation. In terms of the medications we have, you're, I'm sure, mostly familiar with many of these. The important thing to point out is that none of the medications we have alter the disease progression. You often hear people say, oh, well, it slows it down, it does this, it does that. They do not slow it down. They do not change any process in the brain. All they do, when they work, which is not always, is to help a little bit with certain symptoms while people are taking them, but they do not change the course or the process of the disease. They may produce usually modest benefits in cognition and sometimes functional abilities. In early stages, they may help with certain behavioral symptoms, so they're worth trying, but you don't need to use them forever, and not everybody has benefit from them. The two categories we have are the so-called cholinesterase inhibitors. These increase a chemical messenger in the brain called acetylcholine, involved in memory formation, and the main ones available, I'm sure you're most familiar, are donepezil or Aricept, rivastigmine, which is the brand Exelon, which comes in both oral and patch form, and then one called galantamine or Razidine, which again is in both a twice-a-day or once-a-day extended release form. There's a second medication that was initially approved for later stages of dementia. There is some evidence that it may be synergistic or work better together with the cholinesterase inhibitors, and this is a medicine called memantine or Namenda. And again, it comes in both the twice-a-day or extended release once-a-day form. Just to give you a little glimmer of hope for the future, there are some very interesting drugs that are in development. There are immunotherapy strategies where you make antibodies against the abnormal protein amyloid. Early studies showed that it worked well, but it caused brain inflammation and people got encephalitis and died, so that was not a very useful drug. But new versions are being developed that can be used earlier that may have promise. There are medications called secretase inhibitors that help prevent the accumulation of the abnormal amyloid, and the key is to identify people early on and to try these medications early on. Again, they're now in research development. They aren't available for clinical use. Early studies were disappointing, but some of the newer ones are showing some promise. Anti-inflammatory drugs are another line. Attempts at regeneration, so you've all heard of stem cells, and stem cell experiments are being done in animals. There are steroids that are produced in the nervous system that stimulate cell growth and connections in the brain, and there's some evidence in animal models that it may improve cognition. And lastly, and very interestingly, diabetes medications seem to have some very interesting promise. We know that diabetes is a risk factor for Alzheimer's, and abnormal insulin metabolism may be a risk for Alzheimer's. The brain has low levels of insulin, which may impair their ability to use glucose, which is the main source of energy for the brain. And there are some early studies looking at inhaled insulin that gets into the brain, and other drugs that may increase the production of insulin or the sensitivity of cells to respond to insulin that are in clinical trials now. So we have some interesting possibilities for the future. Yeah.
Caused
ulcers, yeah.
A lot of hogwash?
I'm not aware of much mainstream literature. It may be, one of the theories being looked at. I don't think it's been established in any reliable way yet. But nobody believed that ulcers were caused. They all thought it was stress and lifestyle and foods, and We now learn. So I can't say no, but it's not no, I'm not familiar with that, and it's not a mainstream approach right now.
But I didn't want it to be like, I was just wondering if it's just like a lot of, somewhere.
Yeah, not that I've heard of. Okay. And finally, let me get to one of the areas that I deal with mostly, and these are the neuropsychiatric symptoms, the behavioral symptoms of dementia, which again can often be the most problematic and the most difficult to deal with. So dementia is, over and above everything else, it is a psychiatric illness. And if you look at people with dementia, a full 98%, essentially everybody, will develop some behavioral or psychiatric symptom over the course of the illness. And at any given point, about 75% will have these symptoms. So they're extremely common. They can include apathy, agitation, verbal or physical aggression, depression, anxiety, psychosis. And they aren't just a pain for the family to deal with, but they actually have prognostic implications. We now have learned that people who have active neuropsychiatric symptoms have more rapid disease progression. They have a higher degree of morbidity and mortality. They use healthcare system much more frequently, and they often have earlier nursing home placement and, of course, caregiver burnout. So they're very important to recognize and deal with. The most common in early stages are apathy and depression. Just to briefly mention, apathy is not depression. Apathy is a state, it's a neurologic condition where people they simply lack motivation, they lack self-directed behavior, so they may just sit on the couch for hours. It can look like depression. Family may think they're depressed, but if you talk to them, they're perfectly fine. Doesn't bother them. They don't mind. It's fine. So it's not depression. It may co-occur with depression, but it is different. It doesn't respond to antidepressants, so it's important to recognize apathy as something distinct. As the condition progresses, you may see more agitation, both verbal and physical, aggression, psychotic symptoms, which include delusions or hallucinations, sleep-wake cycle disturbance, but apathy is the most persistent symptom that may last throughout the course of the illness. Now, there are different theories of why people develop these. Probably the most likely is the symptom hypothesis, that these are simply related to the degenerative changes in the brain, and these changes affect not only the memory and thinking areas, but also areas that regulate mood and behavior, and they're intrinsic to the degenerative process. Other theories say that, well, maybe not. These might be independent developments, but having the combination of a psychiatric condition and Alzheimer's lowers the coping ability. There's less reserve function, so the symptoms are simply more problematic. And then there's the so-called unmet needs hypothesis, that somebody with dementia can't express what's bothering them, they can't describe pain or uncomfortable feelings, so all they can do, like a 2-year-old might, is to act out with behavior, and that's another possibility. And these aren't mutually exclusive. You may see mixtures of all of these, but I think the most probable underlying are that you have changes in the brain that simply regulate these areas of brain function. Now, before we get to medication, and you've probably heard this, non-pharmacologic, non-medication attempts should always be made first. And you shouldn't just jump to medication strategies unless it's severe. If you have an emergency and severely aggressive behavior, then all bets are off and you have to. But otherwise, you want to try things like optimizing the environment, appropriate assistance with their needs and their activities, but not overly intrusive. I've often seen patients complain that, well, I feel like I have no autonomy. People have taken over my life. I can't do anything. So you want to try to titrate or adjust the degree of help and try to help them maintain whatever abilities they can so they don't feel infantilized or that their autonomy is being taken away. Often a social day program, can help in this regard. We mentioned cognitive and physical exercises. Critically important is how family and caretakers interact. It's very natural to have an emotional reaction and to yell and why are you doing this and so on and so forth. But at all costs, you have to try to avoid confrontation. You have to pick your battles for the most important behaviors. You basically want to just support, delay if they don't want to do something, so do it later. Go away, distract them, change the topic, change the subject, go for a walk. Often this can do wonders to help prevent a more severe escalation, and caretakers really have to be educated about this and not just react instinctually or impulsively. Good sleep practices are important, and you want to tailor activities to what the patient's cognitive abilities and prior interests are relevant for. So people who like to walk, you may want to take them for walks. Music, if they were music lovers. Reminiscence, looking at photo albums of the family or videos. Sometimes, if work was important, just simple repetitive activities like folding clothing for certain people or flower arranging, artistic activities, ball tossing, pet therapy, aromatherapy, massage. These are all things that can have significant benefit. If these aren't working or symptoms are more severe, we get to the medication issue. And the first thing I'm going to say is before you think about adding a medication, my first question is always, what can we get rid of? Because often inappropriate medications are worsening symptoms, and taking away things that are harmful are more important and should be done first before you add new medications. Narcotic pain relievers, what we call anticholinergic medications. These are things that block the memory receptors and cause confusion. The most common culprits are things like antihistamines. I've often seen people get Benadryl at night, to sleep. This is a big no-no. These medications, they make you groggy, but they will dramatically increase confusion. They'll cause constipation, blurry vision, urinary retention, fall risks, etc. So you want to avoid those. Tranquilizers are rarely of any benefit. The dementia medications themselves, the Aricept type medicine and Namenda, may be helpful for more mild behavioral symptoms and maybe all that are needed in some cases. And it's important to point out that there is no medication that's been FDA approved to be safe and effective for these symptoms. So it's all inference and trial and error. Okay, now the thank you. Here we go. Thank you. Here we go. So antidepressants are probably one of the most important medications to consider early on. And these are for two reasons. First, many people with dementia will develop depression, anywhere from 25 to 50%. Depression can look different in dementia. They don't often say they're depressed. They may simply be withdrawn or irritable or angry. They may refuse medication, refuse treatment. So depression can look different in dementia. Antidepressants may be of benefit. They tend to be less helpful than in people who don't have dementia and are depressed. Probably more severe depression will respond better to antidepressant medications. One large trial showed that people with dementia and mild depression, the antidepressants did little more than psychosocial interventions. But again, with more severe depression, they may be very helpful. The other thing to keep in mind is that they're helpful not only for depression, but for other behavioral symptoms. There was one recent study, for example, that showed citalopram, Celexa, a common brand name, was as effective as the antipsychotic Risperdal in treating symptoms of aggression and hostility, and even psychosis, with a much better side effect profile. So we often will first try this class of antidepressant medications, either for what we think is depression or simply for behavioral symptoms. The antipsychotics, many of you are probably familiar. There's been a lot of backlash lately. These medicines have been overused in many settings, especially in nursing homes. They were given out, far too readily. They can have significant side effects. In general, they often have no more benefit than placebo. There are now what are called black box warnings that you read in the drug literature saying there is an increased potential risk of bad medical events like heart attack, stroke, or even sudden death that will often scare people away. And it is true that they're overused and should be used judiciously. However, many of us who deal with these conditions a lot know that for some people they may be the most helpful and the only helpful class of medications. So we should not be scared away. They're most helpful not for nonspecific restlessness or wandering or mild agitation. They're not going to do anything helpful for these conditions, but severe symptoms of aggression, physical or just nonstop verbal aggression, severe anger, active, paranoid thoughts that aren't going away, they can be very, very helpful. You have to use them judiciously, low doses, for only the time frame where you really need them, and you should always try to reduce the dose. But we have the best evidence for the medications. Risperidone or Risperdal is the brand, olanzapine, which is Zyprexa. People with Parkinson-related or movement disorders, quetiapine or Seroquel has fewer side effects since these medications can produce Parkinson-like symptoms. There's a relatively newer one called aripiprazole or Abilify, which may have the least effect on increasing blood sugar or cholesterol or weight gain. So all of these have some evidence base and should be considered when there are really severe behavioral symptoms of the type we talked about. Haldol, more for emergency. I mean, it can be given IM or IV. Thank you. Getting a little hoarse here. But for longer-term use, Haldol has more motor side effects, and you can get a lot of Parkinsonism. But for people in the hospital or people with severe aggression, you can give it intravenously or by injection, and for very immediate short-term use, it can be helpful. I'm sorry?
It's mainly short-term.
Generally short-term. If they need it ongoing and orally, there are probably better options with the newer so-called atypical antipsychotics. Anticonvulsants had a popularity. People kind of use an analogy that some of these behaviors look like people who are manic or bipolar. They, get agitated, they run around, they talk a lot, etc. People were using Depakote a lot or valproic acid. The control trials have shown that Depakote is no better than placebo. So even though it's very commonly used, there is no current good medical evidence that it does anything other than cause side effects. So I do not use Depakote. There's another anti-seizure medicine, anticonvulsant used in bipolar disorder called Tegretol or carbamazepine. There's some modest evidence, but there are a lot of side effects. Similarly, gabapentin or Neurontin, there is some evidence of people, especially with vascular dementia, that it may be helpful with agitation. It has few side effects other than sedation, but again, the evidence base is fairly limited. Family physicians especially will often give the so-called benzodiazepines. These are the Ativan, Xanax, Klonopin, Valium type medications. In general, they don't help much. They may cause paradoxical agitation. If they help at all, it's usually for a limited time. They may have side effects of sedation, confusion. We know that they increase fall risks. So usually we avoid these for longer-term use. On occasion, you may get them for so-called emergencies. If you're going out, they're agitated, you got to do something. So a single dose of a medicine like Ativan may be helpful in that regard, but they are rarely good long-term medication. All of you know that sleep-wake disturbances are very common. With aging in general, and especially with dementia, sleep becomes more fragmented. There's less total sleep time, lower sleep efficiency, meaning it's broken up. You have less deep sleep. There's often increased confusion and agitation at night, which has been called sundowning. And again, the first step is to practice what's called good sleep hygiene. You want to try to have a regular schedule, have a normal sleep time that's not too early, not too late, a regular time out of bed. Don't let people just stay in bed all day, and that can be helped by having structured daytime activity. You want to try to minimize napping because then they're getting their sleep during the day and they're not going to be sleeping at night. You want to have a calm environment and pre-sleep activities. Avoid, obviously, any caffeinated beverages and even any late-night fluids. It'll make them get up to urinate more, so most of the drinking or fluid intake should be earlier in the day. If you need something, melatonin, which you've probably heard of, it's a natural sleep hormone that you can get over the counter. Doses in 3 to 5 milligram range can often be very helpful. You never want to use these over-the-counter sleep aids like Benadryl, Unisom. These are medications that will cause confusion, urinary retention, constipation. They are essentially contraindicated. Typical sleeping pills like Ambien and others are rarely helpful. They may help for a day or two, but they just cause increased confusion and fall risk. For severe and persistent insomnia, some of the sedating antidepressant medicines like Trazodone, which is brand name Deseril, or mirtazapine by the brand name Remeron, may be helpful. They can have certain side effects, but they may have more lasting benefit. And that's all I wanted to say, so thank you for your attention. Dr. Greenberg.
Thank you, Dr. Greenberg. Tonight, the date was set aside based on Dr. Greenberg's schedule. This was important to us that he took off some of his important time and came here and spoke to us, so thank you. We will now have a personal story from Mr. Shlomo Miller, who is a Holocaust survivor, was enjoying his nachas, and his wife was diagnosed with dementia. So please, Mr. Miller.
Kosher assembled audience. At the beginning, my name is Shlomo Miller, you heard. At the beginning, I thought that I am going to use this opening statement to my little speech. And I was going to say, dear fellow sufferers, because after all, we all know why everybody is here. We are all suffering. This sickness is the kind of sickness where the caregivers suffer just as much as the person themselves, and sometimes even more. However, I reminded myself of a story that I heard. The story was from the Brzdivitzer Rebbe. The Brzdivitzer Rebbe was a gewaltige Goon in Achnusis Orchim. He had a special room, he had special bedding and whatever you need for Orchim. He felt the Tsar. We got to remember that this was about approximately 200 years ago or so, when the only transportation that we have was what the Rebbeinu Shalom gave us, what our mothers gave us. There was no such thing as going into a car rental store, getting a car, putting on the key, and voila, you went off. You wanted to go from one town to town, one city to another city, you had to go, you had to use your feet. And never the people that were, can you imagine, Orchim that went from town to town, from city to city, they put a lot of pressure on their feet, on their legs. So he felt the tsar of these people, and he had a special Hachnusses Orchem Stiebel. In those days, there was no such thing as foam rubber mattresses or all the conveniences that we have. If you had a Streusack and a Lalach and a Dochene and a Kischen, you were lucky. So that's what he did. One day, some Orchim came, and of course they came to Brazilitz, and they were his guests. The next morning, when his Rebbetzin got up, and she went to tidy up the room to clean up a little bit, sie ist ihr schwarz geworden vor den Augen. What happened? All of a sudden she sees bed bugs all over the place, lice. So what did she do? She goes to the Rebbe and she says to him, it's a beautiful thing that you're doing to be behind this mitzvah of Achnusses Orchem. However, look what you're doing to me. I have not to contend with a house full of lice. It's going to go from one room to another. The market of kinem we're going to have. So the Rebbe was sitting there and thinking. Then he said to the Rebbetzin, Dear Rebbetzin, you should know that if it is beshed for us to have lice, we will have lice. There is absolutely nothing that you could do about it. However, we got to be thankful to Hashem Yisburach that we didn't have to go far away. We didn't have to go to Boibrik to get the lice. The lice came to us. Of course, I'm not comparing us or myself to the Rebbe or to those people. However, when I thought about that story, I nixed that opening statement. Instead of that, I chose a different statement. I chose a Maamar Chazal. The Chazal tell us, Poischen bechvoit achsanya. As I should have mentioned before, Leah Horowitz bestowed upon me the great honor of addressing you tonight. And therefore, I feel that I owe Leah Horowitz at least that much to say something nice about her. And I believe that most of the people who are here owe Leah Horowitz also gratitude. So I thought I'm going to tell you a medrash. I didn't see that medrash personally, but my father, Uluf Hashum, who was a great Talmud Chacham, told me this medrash. Everybody knows that Shlomo HaMelech was the wisest, the smartest person, the Chacham Mikol Udam. In his time, the Yidden in Eretz Yisrael lived, as it says in the Pusik, Ishtachas Gafnoi, Ishtachas Teinusoi. There were no wars, there were peace, and everybody was happy. The Ashmedai, who was the head of the Shadim, was very jealous at Shlomo HaMelech's success. And he knew that his koyach was in a certain golden ring that he had that had engraved certain shemes, and he was trying to scheme to get that ring out of Shlomo HaMelech. And therefore he will have power over Shlomo HaMelech. It wasn't an easy task, but if you try hard enough, you succeed. Somehow or other, he got Shlomo HaMelech to show him that ring, and he grabbed it away from him, and he threw him to the end of Eretz Yisrael, all the way the other end. Shlomo HaMelech was left without his kingdom, was left without his palaces, was left without his throne, was left like a beggar. He could have used the Brezhnevitzer Rebbe to give him a night's lodging. And he could have used the Nushim Tzadkunius and the Nushim Rachmunius to give him a night's supper. The Chazal say that Shlomo HaMelech at the beginning was king over 120 Medinas. At the end, meaning after the Ashmedai did what he did, he was a king over his cane and over his rucksack. So he needed a night supper. What does a Yid do? Knock on the door, ask the balbuster whether, and he says to this first balbuster that he sees, I am Shlomo HaMelech. I didn't eat the whole day. Would you do me the great honor and give me a supper? Yidische Kinder are Rachmunius, Atzidkunius, of course. Come in, Achnus Esochem, a great mitzvah. Wait a minute. Aren't you the man that said, Udom echod me'elef mutzusi, ve'ishu b'chol eila loy mutzusi? Yeah, I said it. Slammed the door in his face. I found one righteous man among 1,000, but women I didn't find not even one. So of course that didn't go over well with the ladies. So of course he didn't get his supper. And he went to the second house, oto davar, went to the third house, oto davar. Ladies and gentlemen, I forgot to tell you one little thing. This story happened about 2,400 years ago. There was a time that there was no Leah Horowitz. There was no ladies like her who does so much for the community. I myself, my daughter Zicharon stark, we went to her. We got hit with this Alzheimer thing. My wife, Zicharon stark, got it. We didn't know where to turn. So they told us there is a lady, and we found that she was stuck, very helpful. She directed us where we should go, try to get whatever help we can. I believe that we all owe a gratitude to Leah Horowitz. And I'm going to ask you, Khrushchev audience, please give this little lady a big hand. Thank you very much. I was also told that Leah Horowitz has a very, very good helper. I believe her name is Lorraine. She's a social worker. Whenever she needs her for lectures, for whatever it should be, I believe she should also get a nice hand. Moirav Rabbi Sai. It says by Noach that Noach saw a world that was built up, relatively so. Noach saw a world that was chorub, Mabel came. Noach saw the world that was built up again. I can also say I saw a world that was a world. I saw Europe. I was 16 years old at that time. Beautiful Yiddishkeit, beautiful yeshivas, beautiful institutions, schools. We come from Ashkenazic areas, Talmidei Chassam Sofer. The Oberländer Yiddishkeit, which today is probably gone because Yemach Shmoi made Churev the whole world. But before the war, there was a beautiful Yiddishkeit. There were yeshivas, there was Sadheller Yeshiva, Galanter Yeshiva, there was Pupa Yeshiva, the Shuraner Yeshiva, Nitra Yeshiva, beautiful yeshivas, beautiful Moses, and the Yiddishkeit mamish blossomed. What tzedukah v'chesed these people did, how they helped each other. It was me, through a 16-year-old boy, I saw nothing but beauty. That was Oilem Buni. Then, everybody knows what happened. This terrible, horrible Chorban came, the worst destruction that humankind ever experienced. Killing of 6 million Jews for absolutely no reason. I had a brother 3 months old that when you came into the room, mamish, he lit up and the room lit up. What did this kid sin? What did he do wrong? Why did he have to be killed? And I see now, Baruch Hashem, that we have, again, yeshivas. And if you don't mind, I'm going to tell you, we have Beis Yaakovs. In one of the Beis Yaakov high school teachers is my daughter, Rebetz Malki first. Probably many of you know her. I have a son who is a Rebbe in Lakewood. I have a son who is the son-in-law of the Rosh Yeshiva in South Fallsburg. And I see beautiful, again, the Renaissance. I see it coming back. Whenever I talk about the Churban, I talk sometimes to school kids. I believe that they should know about it. I usually start out with a story of the Belzer Rebbe. After the war, of course, everybody knows that all the shuls, all the Butei Medrushim, all got destroyed. The Sheretz HaPleiter that came back to Antwerp, and Antwerp had a Belzer Stiebel. They built up the Belzer Stiebel again, and they were so proud of the job they did that they sent a shliach. They sent a shliach to the Belzer Rebbe, who was at that time in Eretz Yisrael, that he should take part in the Chanukah Habayis. The Belzer Rebbe, once he was in Eretz Yisrael, he didn't want to leave. But he went ahead and asked his brother, the Bilgarai Rebbe, that he should come instead of him. And he told him to say these words to the Belzer Hasidim in Antwerp. You should know that there was a Gezeira min Hashmayim lahashmid laharek al-abed es kol ha'idim. Any person that was left alive had to have two maluchim that were watching over him. Moray Rabbi Isai, I can tell you that I am a personal witness of what the Belzer Rebbe said. I'll tell you a few stories about myself, what happened. Can you put down that thing, those pictures? Does it work? I just want to show you some pictures of the concentration camp. Yeah. Yeah, the top picture is where when we disembarked from the cattle car. When we disembarked from the cattle car, the bottom picture is where we disembarked from the cattle car. The top picture is when we were told to march towards the front. Thank you very much.
We have 5 minutes, okay?
Okay. When we got disembarked, and the minute we got into camp, they started hitting us, and they were saying, "Lauf, lauf, lauf, schnell." They couldn't wait to kill us. They were in a hurry. I was a 16-year-old kid, like I told you, and I ran to the front I wanted to see what's going on here. I saw the German soldiers, Yimach Shemam Zicharon. They were telling the people where to go. Of course, women and children were killed immediately, and the rest of us were killed a little bit later. And then I went back to look for my mother and the other children. I went up and down 3 times. I didn't find anybody. Didn't find my mother, didn't find the children. I came, so I decided, what am I going to do? I'm going to go. So I went. I was a tumult. I was 16 years old. And I see a chaver miner goes right in front of me. I don't follow him. But there was another Jew from our town. I decided to follow him. This Jew was a conservative, neolog, had nothing to do with them. But I decided I'm going to follow him. As I go, and he went to the right side. The right side meant to go where you're going to go to work and you have a chance, maybe you'll live. Moray Rabbi Sai, think about it. Think of what happened in those few minutes. I lost my mother and the children. Had I not lose them, I would have gone to the left side. Did I tell you that a German soldier was running after me to try to get me back because Dr. Mengele Yimach told me to go to the left side? I was a little kid. Without the Belzer Rebbe's explanation, you couldn't possibly understand what happened to me in those few minutes. What happened to me, I lost my mother, and because of that I was alive. What happened to me is I did not follow my chavrusa, I went by myself. What happened to me is I didn't look what Dr. Mengele was telling me to do, and I just followed this man. A soldier was running after me, he didn't catch me, and I didn't know what was going on. So there are so many evidences that a malach was watching over me. I don't have much time, I'm already on overtime. But I'll just tell you that, Baruch Hashem, I have a beautiful family. I have 37 grandchildren, great-grandchildren, I don't even know how many I have. 4 of them got engaged in the last 4 weeks. Now I'm asking you this question. If 70 years ago, when I was in Auschwitz or I was in Mühldorf or in the other camps, if somebody would have told me, you should know, you'll come to America, you'll have a nice family, the only thing that you will have to suffer a little bit is that your wife will be afflicted with this terrible disease. I married one of the most wonderful people in the whole world. I married 60 years ago. We had shulam bayis, the best that there is. Am I entitled to say fellow sufferers? Are you entitled to say fellow sufferers? Are we entitled to say fellow sufferers? No. what we're entitled to is to pray to Hashem that he should send the refuah shlema for all the people that are suffering, and everybody should be healed the way they are supposed to be. Eventually it'll happen, but we need chizuk. Until then, we should not let the Sultan get us, and thank you very much for listening.
Thank you very much. I want to ask you, Mechila, for calling you Mr. Miller. Probably should have been Rabbi Miller. Thank you. Before we go to our last speaker, I was asked to speak about, for 2 minutes, about the FIDA program. FIDA, F-I-D-A. Anybody knows what I'm talking about? A lot of you are getting home care services. The way New York State works today's day and age is you have to be enrolled in a managed long-term care plan. It's a Medicaid plan. Medicaid pays the plans a set amount of money every month, and they are in charge of this, giving the hours and deciding how much home care services you get. That's still going to be the way it's going to work, but they are now starting something called FIDA, a fully integrated dual advantage. That's going to start affecting your Medicare portion, the portion that controls your doctors, hospitalizations, x-rays, pharmacies. All of it is going to be working with the same case manager. So if you thought your case manager never gets back to you until now, she's going to have 1,001 more things to do, and she's going to call you back a lot quicker. That's FIDA. Now, FIDA is a fully integrated dual advantage. The advantage portion of it means it's an optional, it's like an HMO. What they're not telling you is, they may be telling it to you, but you're probably not reading it in the little words on the bottom, is that it's an experimental program. The federal governments are giving New York State a lot of money to do a pilot program to see if it can enhance the care, if it could reduce hospitalizations, if it could save them money, is what they're trying to say in parentheses. That's being done through an experimental program. So when you're getting enrolled into these plans, these are plans that have maybe, as we speak today, 100 members enrolled in them. They're really experimenting on you. It's not something anybody would say is a good idea, but the good news is that there's a way to get out of it. It's not a mandatory enrollment like MLTC, like managed care was. It's a passive enrollment, which means you're getting a letter stating that this is what's going to be happening in 90 days. If you don't do anything, you're going to be enrolled. You may get another letter, 60 days, 30 days, and then you're in. So I suggest that you think about it, and before you decide to throw it away, think about it. It may be a good idea. There are 1 or 2 benefits to it, but you should think about it. The benefits that they say is, first of all, you don't have any copays. It takes care of everything. Your Medicare, your Medicaid, you only have 1 card. You don't have to deal with 1,000 different cards. Every time you go to the doctor, you pull out the whole wallet. It's 1 card. It's in charge of everything. That's officially the benefit, so it doesn't confuse people. That's one benefit. The other benefit is something that's a brainstorm. They came up with something called an interdisciplinary team, which means your doctor, your care manager, your home care provider, family member, and the patient are going to be a team, and every 6 months you're going to sit down around the table, most likely the dining room table of the patient's home. And they're going to talk about their care plan and the right way to care for them and what should be done. It's a very good idea. But you tell me again if your doctor ever returns your call or if he has extra time, let alone travel to the patient's home minimum twice a year, up to 13 times a year, to have time and spend for all of that. So it's a great concept, but it's not something that's going to work. So again, it's experimental, it may work, it's the benefits that you should have, but ultimately don't think you're going to have. It's called FIDA, F-I-D-A, Fully Integrated Dual Advantage Program. Everybody in MLTC will be passively enrolled, except if you pick up the phone with a 1-800 number and you say, I do not want to be part of this program. Is the Medicaid program, the Managed Long-Term Care Program. Anybody that's receiving home care services, 97% are on an MLTC. I'll have the number for you in the back. Medicaid. Nursing homes are going to be part of FIDA. I'll give you a very good example. People that are on Medicare, can choose anybody that accepts a Medicare provider. If you're in FIDA, it's essentially like you enrolled into a managed care. So now you have to go to a provider that's in the network. You need to wait for an authorization. And that's where they're going to become creative in saving money by not giving authorizations. So if you need an x-ray, they're going to say, well, you had an x-ray 3 weeks ago. Well, your new doctor just ordered another x-ray. So again, that's the kind of things where you're going to need to have authorizations. There's another common difference would be, God forbid somebody ends up in a nursing home. If you have regular Medicare, you're probably going to get about 2 hours of therapy a day. If you're in FIDA, it's an insurance plan, they're going to want to see progress notes, they're going to give you a little bit, maybe 30 minutes a day. So you're in a great program, but when you need them, they're probably not going to step up to the plate. Another example. Sorry? I don't have it with me, I'll have it for you in the back. Okay? You can meet me. I'm the owner of Elite Home Care, so I'll be standing by the desk back there. Mic up. I'm getting a stiff neck, right?
What do you recommend?
I'm sorry?
What do you recommend?
I recommend that you educate yourself about what your options are.
What do you recommend?
I'll talk to you about that. I'll give you. I'm being videotaped.
So what?
That should give you the answer. The other big difference is there's one of the vendors back there called Homeside Rehab. A lot of people think once you're in an MLTC, you don't have the option of getting therapy services at home. You could still get therapy services at home, even in an MLTC, without getting authorizations from the MLTC, if you have straight Medicare. If you have straight Medicare, you can get it. However, if you're in FIDA, once again, it's one of the services that you're going to need to have a case manager approve, and of course they're not excited about approving additional services. MLTC is a managed long-term care plan. Anybody that's getting home care services in New York is either paying for it privately or they're getting it paid for by Medicaid, which is under an MLTC program. Any questions? That's very true, and it's a big problem when you get passively enrolled and all of a sudden you go to the doctor, they run your insurances and say, you can't see the doctor today. Officially there's a way that they address that issue, but your doctor's not going to wait on hold for 45 minutes to get clarification if he can visit you, if he can see you or not. Sure. Mm-hmm. Private long-term care or managed long-term care by Medicaid? Okay. So if they're not on a Medicaid program, there's nothing to worry about.
Okay, but after those 3 or 4 years, that it ends, that the person has to be put on Medicaid. Once they put on Medicaid, then this whole shebang starts with the...
with the MLTC. Anybody that's getting admitted now to a nursing home is also has to go on to MLTC. That's a brand new change that just happened now.
Okay, so if they're on the MLTC, excuse me, sir, if they're on the MLTC, with that other,
FIDA.
is that part of the whole business or no?
At this point, it's optional. It's optional, but they're not telling you it's optional. They're telling you you're being enrolled, except if you call up to say you don't want it. I'll be happy to take any questions in the back. It's really Matt Kudish, the Senior Vice President of the American Alzheimer's Association, New York City chapter. You're clapping for him, I'm assuming. He really deserves it. He's been a tremendous friend of Zicharon. He's been very, very instrumental in getting all the help, the shops, the workshops. He's a great friend of the organization. We thank him for that, for the years of support. And Matt.
Hello. What a warm reception. Thank you so much. I didn't even do anything yet. Oh. I'm sorry. Okay. I'm sorry. It's fine. It's fine. So we have a slide show that we're going to put up. I did put together quite an extreme presentation, and so I think for the interest of time what I'm going to do is skip through some of it. And to be honest with you, I think that the most important thing that I can say at the beginning is we do not have enough time to really unpack the issues that we're here to discuss tonight. It's very, very complicated, as each of you in this room already understand. To enhance the ability to effectively communicate with people with Alzheimer's disease, to manage some of the challenging behaviors. These are very, very big issues. And in an hour, 45 minutes, 2 hours even, frankly, it's really not enough time, because what we're trying to do, the goal, every time I come and talk, and it's really my pleasure to come back year after year, when I come, what I'm thinking is it's important that I plant the seeds to bring about a shift in your perspective. Because if we want things to be different than the way they are now, as it relates to our ability to meaningfully care for somebody suffering from Alzheimer's or any other cause of dementia, the onus, the responsibility is on us to change. Right? We know from Dr. Greenberg's terrific presentation that this is a disease. These are diseases that we're talking about. There's a pathology here that's resulting in the changes that you're seeing in the person for whom you care. He or she is doing the best he or she can. And I think too often we think that we can shake the dementia out of someone by either helping orient them to what day it is, or helping them better understand who the people are around them, or quizzing them about what they had for breakfast, or quizzing them about, do you know who the people in this photograph are? That's all for us. That's not for the person. So if we want the relationship, which is key here, Dr. Rosenberg talked about how important non-pharmacological approaches are when we're trying to engage more successfully with people with the disease. The key is relationship, and that all starts with communication. So that's what I'm going to really focus on today. One little sidebar before I get into that. I know there were a lot of questions, and I think a lot of head scratching when the gentleman before me from Elite Home Care was talking about MLTC and FIDA and lots of other acronyms that are very complicated. They are really complicated, and I think the most important part, my 2 cents in that, is be good consumers of this kind of information. You're now charged with making decisions for yourselves, for your family members. It's imperative that you understand the implications of these choices so that you can make the most informed decision that makes the most sense to your needs. So they're in the back here. They can answer some of your questions, I'm sure. The Alzheimer's Association, free. You know our number, I'm sure. It's on all the materials that are out in the lobby. We have a lot of information we can share with you. Not recommendations, as somebody asked for earlier, but information so that you can make the best decision for your individual situation. But it is very complicated and complex and difficult to boil down to 3 minutes. So that's my little piece about that. So now, I'm going to skip. You're going to have to forgive me for this. It's so we can really get to the heart of the issue today. So I'm going to start here, and I sort of alluded to this. At the chapter, we talk about the theory of the two worlds. And I think this is a really important distinction that we make. There's the world in which we live, which is rooted in reality and facts and reason and logic and information, right? And good, sound judgment, hopefully. And then there's the world in which the person with dementia is living, which is really, unfortunately, because of the disease, not rooted in any of those things in which we often take for granted. Our ability to engage in a meaningful conversation with someone with facts and reality and insight and information is very different than the world the person with Alzheimer's and other causes of dementia is living. They're rooted in their reality, which may be very different from our reality. And too often we try and drag the person with the disease into our world by doing those things I alluded to earlier, by quizzing them, by asking them if they remember what happened earlier today, if they remember where they are and who the people are. All of those things that we do are our attempt to try and drag the person into our world. And the challenge that I give to all of you today is, rather than drag them into our world, we must step into their world and really spend some time there. And that takes a lot of time and practice, because it's very different from the way that we've historically engaged with these people. So when you look at somebody with Alzheimer's disease, for a long time they seem the same. They look the same, they can sound the same for a long time throughout the spectrum of the illness. It can be very easy for us to forget that something medical is going on, right? And because we're human beings and we're fallible, we lose our patience, we get frustrated, we don't understand how they don't know what happened 5 minutes ago, but they know with such specific detail what happened 45 years ago. And it makes us nuts, because we think, well, they're doing it on purpose, or they're not ill, how can this be? They're trying to manipulate me, they're doing it to spite me, she was always like this. All these things that we put on it. We have to remember that they're doing the best that they can. And really it's up to us, again, to shift our perspective, to remember that there's a disease at play. But this is tough stuff. It's not easy. So hopefully today I'm going to give you some strategies that will enable you to better prepare yourselves to step into the world of the person for whom you're caring and really develop a meaningful relationship and connection there. Because the outcome of this is an enhanced ability to engage the person meaningfully, so that you can more effectively communicate with them. And that's at the heart of then mitigating and reducing the kinds of challenging behaviors that we tend to see in people who are suffering from Alzheimer's and other causes of dementia. So at the heart of this is communication, and the key really is for us to recognize that one's ability to communicate effectively with words is profoundly affected even early on in the disease. So in the early stage of the disease, maybe it's word finding or phrase finding. So you ask me how I got here today, and I say, well, I took the metal people mover that goes under the ground. I know exactly how I got here, but the word escapes me in that moment. But you know, based on my description, that I took the subway, right? So in the early stage, those are the kinds of problems that you can expect to see in terms of communication. But by the middle stage of the disease, it's much different. Much more of the brain is now affected by the disease, and we lose about a quarter of our vocabulary. About 1 of every 4 words. Imagine if you didn't understand 1 out of every 4 words I've said so far today. I think this would be a much more complicated, difficult presentation for you to follow. So they don't understand largely what we're asking of them, and conversely, it's much more difficult for us to understand what they're experiencing and what they're feeling. And by the late stage of the disease, in most cases, language is lost. And so it becomes profoundly difficult to have meaningful communication in the way that we have always communicated with this person. So relationships are so complicated, right? When we interface with a family, we come in at one very specific point of time. We don't have the dozens and dozens of years, the decades that you have with this person. With that family history can be so complicated and so complex. And our expectation is that this person, who again may look very similar to how he or she always has, may sound and seem very similar to how he or she always has, we have the expectation that we're going to be able to communicate with them in the way we always have. And this slide really here, I think, delineates what some of the more inherent challenges to that process really are all about. So recognizing the communication difficulties that exist throughout the spectrum of the disease means that we must figure out new ways to enhance our ability to communicate effectively. Okay, great. So we're going to go through some of these lists of communication do's. And again, what I wanted to give you are operationalizable, I'm not sure that's a word, but things that you can take home with you today and try to put into practice. So we're going to start at the beginning. Knowing this individual is key. And I don't mean knowing their name or where they're from or who they are to you. I mean really knowing on a deep level what this person was like before the illness took hold, before the dementia symptoms began to present themselves. What were her favorite foods? What were some of his favorite scents? What kind of music did she listen to? Did he like children and dogs or cats? What are some of the personal hot buttons or stressors? How did this person react to stress in the past? What did this person do for a living? What was his or her daily routine? What time did they wake up? Did they shower in the morning? Did they take baths in the evening? Knowing as much as you can about who this person is not only enhances your ability to communicate with them, but these give you tools in your toolboxes so that should the person begin to exhibit some agitation or frustration or anxiety or stress, you can use some of this knowledge that you have about this person to get in there and do what we call is make the brain a better offer. So if you think about somebody with Alzheimer's disease getting very focused on one thing, their brain is dealing with that one issue. If it's causing them anxiety or stress or fear or frustration, that's what their brain is focused on right now. But if we know that this person likes chocolate or Beethoven or babies, then we have real information that we can then use to make the brain a better offer and hopefully reduce some of those challenging behaviors that the person is focused on and reduce some of the symptoms that are manifesting because of what that person's attention is really on. Does that make sense? Okay. Go slow and go with the flow, right? We need to manage our expectations. If it used to take a half an hour for someone to get ready, we need to leave 45 minutes or an hour. If we go in there expecting them to be able to move at the pace with which they've moved before or at the pace with which we move, we're setting ourselves up for failure. We need to set ourselves up for success, recognizing that it's going to take people longer to do tasks that they historically have been able to do with relative ease. All of those old things that we take for granted, like making coffee in the morning or making a sandwich or brushing your teeth or getting dressed or making a phone call, all of these kinds of things, getting ready to leave the house, we need to set ourselves up for success, because if we only leave 20 minutes and then we get anxious and we get frustrated because we got to go or we're going to be late, that anxiety that we're feeling is going to transfer right to the person with the disease. They may not understand the context of what's going on or why there's such a pressure situation, but it will largely impact their ability to get done what needs to get done. So when we go slow, go with the flow, allow for more time for traditional activities to take place, then we reduce the likelihood that we will get stressed, thereby creating a much more peaceful, calm atmosphere and environment for the person, which will allow their quality of life to be enhanced too. And frankly, I bet each of you in the room would benefit from a little less stress, right? So if we reduce our own stress, reduce their stress, it just becomes reciprocal and everything starts to become a little bit easier. But if we walk in the room very kind of anxious about all the things that we have to get done and how little time we have to move forward, from the start we're creating a situation that's probably not going to go as well as we would hope. Using familiar words or phrases. We want to maximize their ability to understand, recognizing that their ability to use language is now impaired by the disease. A good rule of thumb is 5-word sentences. Avoid too much information. No one needs to know that there's a doctor's appointment a week from Friday, a week from Tuesday. That's way too much notice, because now it's going to be, when's the doctor? Are we going to the doctor? When are we going to the doctor? What time is the doctor? When are we going to the doctor? Where's the doctor? Right? So this is happening, right? This is, okay. So we want to avoid too much information. That doesn't do them any good. We want to be very deliberate with the messages, short and specific information. 5-word sentences is a good rule of thumb. One of the worst things we can do, and we do it all the time, is, well, now we're going to have lunch, and then after that we're going to do this, and then we're going to get ready and go out of the house, and we're going to go to the park, and after we'll go to the park, then we'll stop at the doctor, and we'll come home and watch some TV. And all they hear is TV, or all they react is, well, what? Right? It's too overwhelming. So again, it's about setting yourself up for success by setting the person up for success. So those short, direct message about what's happening right now, avoiding too much information, right? Give simple choices, not what do you want to eat or what do you want to wear. We want people to have some control over what's happening to them, but we want to manage the choices so that it isn't overwhelming. So you might say, do you want chicken or fish? We might say, do you want to wear your red shirt or your blue sweater? So that the person is making a decision over what's happening, right? We're not taking all their independence and their autonomy away, but we're not giving them the menu of a diner, which is 25 pages long and has every kind of food that you can probably imagine, right? We want to manage it a little. So maybe if you go out to a restaurant and there's a menu that might be overwhelming for the person, you can say, when you come here, you usually get the chicken. Is that what you'd like today, right? So again, we're setting them up for success. But what do you want to eat could be setting us up for a disaster. We want to break down tasks. So rather than saying, go to the kitchen and make lunch, we can do it together, right? Everything can be an activity. Activities don't have to be these very big, complicated things that become stressful, more stressful for us. Everything can be an activity. Making a sandwich can be an activity. But telling somebody with cognitive impairment to go make a sandwich can be too overwhelming. So we need to help them better understand what the task at hand is by breaking it down into steps. One of the exercises that we do in some of our workshops is, if you're going to make a peanut butter and jelly sandwich, write down all the steps. Because we think, make a peanut butter and jelly sandwich. Go, I'll be back in 3 minutes, and I'll have a peanut butter and jelly sandwich, right? But for somebody whose ability to use their executive functioning to come up with a plan and put that plan into action, making that sandwich is going to be a bigger challenge than you might believe. So if we think about what goes into making that sandwich, it's getting the bread and getting the peanut butter, getting the jelly and getting a knife. Maybe it's toasting the bread, maybe it's putting the peanut butter on the bread, maybe it's washing the knife so that the peanut butter doesn't get in the jelly, maybe then get the jelly, put that on the bread, put it together, maybe it's cut the crust off, cut it into squares. It can be very complicated. We're experiencing it through our reality, right? What we see is determined by where we sit. So if we're sitting in a place where we are using reality and facts and reason and logic and judgment, then it's not complicated to go make a sandwich. But we have to remember that the person we're engaging with isn't living in that world right now. They're living in a different world. And if we're going to spend time in their world and step into their world rather than try and drag them into ours, these are the kinds of things that we want to be thinking about. We have to put ourselves in the shoes of the person we're caring for so that we can maximize their ability to do things more successfully, which then gives them a feeling of accomplishment. If you're engaged in something that brings you pleasure, you're not yelling and biting and screaming and getting angry, right? It just doesn't work that way. Think about the last time you were participating in an activity that brought you real pleasure. You probably weren't feeling angry or anxious or frustrated or mad. So if we can create an environment in which the person is engaged in something meaningful, then their quality of life is enhanced, their mood is enhanced, and that will affect our mood as well and our quality of life. Take some of the pressure off. Ask if the person will help or if the person will try. This is a big one because people often don't want to be recipients of support and assistance. People generally are much more interested in helping other people. So if we come in and we say, well, you have to, or you need to, or it's time to, the person may not react in as open a way. But if we say something like, I know you don't want to do this right now, but will you try for me? Will you do it for me? You may get a little bit of a different reaction. And again, it's just a slight shift in the way that we're approaching this. Acknowledging the person's emotions. rather than the facts of the situation, respond to what the person is expressing in terms of their feelings. If we relate on an emotional level, then it's less about what they're doing, and it allows us to tap into more deeply why. What's going on for this person? What's the unmet need? What's happening here that may not be able to be communicated meaningfully in words, but through their emotions and their feelings, we're able to tap into and understand. And when we understand the underlying emotion and reflect that emotion back, then we're really getting at what the issue is. The issue may not be the sort of top line, the facts of the situation, the words or the action that the person is exhibiting. It's what's underneath that. And we're going to talk a little bit more deeply about that when we talk about some of the behavioral challenges. Be prepared to have the same conversation over and over again. How many of you are dealing with repetition? It's a very common symptom, right? How many of you get frustrated by being asked the same question over and over again? Those of you who didn't put your hands up, I don't really believe you, but it can be frustrating, right? I'm not going to stand up here and tell you, come on, this is easy. We're all having fun providing care for people with dementia. This is very hard. And it's emotionally charged because these are people for whom we care. We have a deep affinity for these people, and we're seeing them declining and changing in ways that we never expected and would never hope would be happening. So the emotional impact of caring for somebody with the disease can never be removed. That overlays everything we're talking about here. And I would be lying if I said, put that aside and just deal with these concrete approaches to engaging more successfully with someone. We cannot remove the emotional impact of seeing someone we care for declining from these diseases. But if we go in with realistic expectations, we know they're going to be repeating themselves. We know they're going to be confused, right? We know they're going to ask us what time it is 20 times in 15 minutes. We know that they're going to get stuck on something and ask the question. But if we understand that it's going to be like that, if before we walk in the room we have a moment where we just take a breath and we say, this is going to be hard, we set ourselves up for success. We are less likely to lose our patience and get frustrated. When we get frustrated, all that does is escalate the situation until it becomes overwhelming for everyone involved. But if we go in and don't let it bother us, and I'm not standing here telling you that that's easy to do. It takes time, it takes patience, it takes a real commitment. It takes forgiving ourselves when we make mistakes, because we are going to make mistakes. I think too often we put unrealistic expectations on ourselves, and we think that we need to be the perfect caregiver. That is a bar that is set way too high. You are setting yourselves up for failure. There is no such thing as the perfect caregiver. There is no such thing as the perfect caregiver. Give yourselves realistic expectations so that you're fairer to yourselves, right? Is guilt and frustration. Do we beat ourselves up when we make mistakes? Do we feel horrible when we lose our patience and get angry at the person with the disease? These are things that are going to happen. None of us is born with the skills to provide this kind of care with people with the disease. It's not innate in us. It's a set of skills that we can learn. But it takes time, the same way that it takes time to learn anything and everything, right? So we need to be more fair to ourselves. Give ourselves a break. Understand the challenges that are inherent in this type of care. Recognize that these changes and the shift in perspective. I mentioned at the beginning, I'm planting a seed to begin the shift in your perspective. I'm not saying in 45 minutes everybody will have made that shift, right? We need to be reasonable with ourselves and set ourselves up with reasonable expectations. The last one here is interesting. Only ask, are you ready to, if you are ready to come back later. Because if we say, are you ready to take a bath? And the person says, no. What do we do, right? We're not going to say, well, too bad, come on, we're going to do it anyway. We have to say, well, okay, and come back later. A much better way is trying to set ourselves up for success might be, let's take a bath. Or run the bath in advance and don't say, we're going to take a bath in 20 minutes, or tonight we're going to shower, right? That's too much information, right? Then there's anxiety already about that upcoming event. What we might do is get the bath ready. warm water, the lights in a way that create a sense of calm. Knowing the person, right? Knowing what their favorite smells, knowing their favorite music. If there's a perfume she's always enjoyed, spray it in the bathroom so that when she walks in, there's a sense of comfort, a sense of familiarity in the room. Put on the kind of music that he or she has always listened to and really enjoyed. Make bath time a different kind of experience. And I think sometimes, and bathing I know is an issue for a lot of other reasons, and people in the middle stage especially become resistant to personal care. People who are Holocaust survivors have a lot of other issues with bathing, and I did put some specific strategies to that I'm going to talk about in a little bit. But if we can take some of the grab away from a stressful situation, I imagine when we think about having to bathe the person, it brings up so much stuff for us. Whether it's a dignity issue of not wanting to see this other person naked, or not feeling that the other person is comfortable with you seeing them in that vulnerable situation. Bathing people with dementia is not something we've sort of prepared for our whole lives, right? These are difficult situations for anybody. But I think, too, that the idea we get in our own heads about the impact of having to do this in such a way that we go in with a high level of anxiety. Maybe we're anticipating a level of resistance of the person because the last time we tried to do it, it didn't go so well. But if we again, I know I'm repeating myself, we set ourselves up for success by creating an environment that's calming and more inviting and soothing and not anxiety-provoking for us and for them, then maybe we'll have a little bit better luck. So instead of saying, do you want to take a bath, or is it okay if I clean you now? Maybe we just say the tub is filled with warm water. And again, the language that you're going to use, the strategy that you might use, it's all dependent upon your unique situation. So don't think the way that I'm saying it is the way that you should then employ some of these tactics. Really, my purpose here is just to get you to start to think a little bit more creatively. Instead of, well, this is the way that things have always been done, maybe if we come at it from a slightly different angle, then we may have even greater success with engaging with the person more meaningfully. Is some of this resonating with you? Yeah? Okay. So we talked a little bit about the importance of trying to understand what the person needs or wants. This is really about recognizing that their ability to communicate in the old ways is no longer going to work. We can't rely on them to tell us when something is wrong in the same way that we used to. So rather than wait until someone starts to get upset, we want to create an environment of calm and comfort. I think we think when we see somebody agitated or anxious, we think, well, what can I do to calm them down? I challenge you to think even more in advance so that you're not waiting until somebody is experiencing anxiety, but our purpose, our goal is to always be thinking, what brings about a sense of comfort for this person? What can I do in the environment that can bring about a sense of calm? Regardless of what time of day it is, what time of night it may be, whatever else is going on, how can I anticipate what the person needs so that those needs are never unmet and we're never dealing with a catastrophic situation? Because that's often what happens, is things just sort of spiral out of control, and then everything is up here at this very high level, and we're responding to that emotion that the person is giving off, and we're feeling really unprepared or underprepared to know what to do. And so our feelings of escalated anxiety and stress is feeding off of theirs, which feeds off of ours, and then everything sort of becomes too overwhelming and too big. But if we can anticipate what people's needs are, recognizing patterns, maybe there are times of day when the person tends to become more upset or agitated, think about ways that we might bring about a sense of calm 2 or 3 hours before that time of day. Sundowning, is that a phrase or a word that you're familiar with? It's a theory about when someone becomes a little bit more anxious and agitated around 4 o'clock in the evening, 5 o'clock in the evening, or when the sun starts to go down, hence the name. If we know that this is something that happens pretty much every day with someone, let's start to think, now that we're thinking about what do I know about this person, his preferences, or the things that she never liked, right? Those tools, if we can employ them in advance of a difficult situation, in advance of some of these behavioral challenges that are really getting in our way, then we may see those behaviors start to dissipate. We may be able to head them off at the pass. Using empathy, we talked about that, right? Relating on an emotional level, relating to the feelings that the person is experiencing and not just the facts, not the information that they're sharing, because the information they're sharing may not be rooted in our reality, right? If they think that it's Saturday and it's time to go to shul and it isn't, and are trying to relate to them about the information that they're saying, we're arguing with someone who doesn't have the ability to use reason and logic in that same way. So if we're saying it's Thursday, or it's Tuesday, or it's not the holiday yet, that's our reality, right? That's our world. And we're dragging, when we react in that way, when we try to correct someone or argue with them about the facts, we're missing an opportunity to engage with them. Has anyone ever argued with somebody with Alzheimer's disease? How's that gone? Not well, right? It doesn't. What should we do? No, correcting them is engaging with them on the facts of the situation. So we can redirect them. We want to acknowledge the emotion, right? Their reality. It's probably some level of stress where they're feeling that they're supposed to be somewhere and they're not. And we can say, I can see that you're very anxious. And so that's relating to them on the feelings of it and not arguing with them about what's going on. And we try, once we have their attention, we try and distract them with something else, an activity that has historically brought them pleasure. And this is really where knowing the person comes in. So I can't give you I know you want me to tell you exactly what to say and exactly what to do and make it all better. I wish that I had the ability to do that. I really do. Unfortunately, it's going to be different with every person that you're caring for. You know, as we heard earlier, dementia, Alzheimer's disease, these are diseases of the brain. And because each of our brains is unique, the way that the disease is going to manifest, the way the symptoms are going to present themselves is going to be different in each person. So what may work for the person for whom you are caring may not work for someone else. And what may work for you today may not work in 3 hours. It may work again in the morning, and then it may not work again ever, or it might work again in 3 days. So it's much more sort of gray than it is black and white. But when we try and relate to the person on that factual level, that is exactly what I'm talking about dragging them into our world. They don't have the ability to understand. They obviously think that they are supposed to be somewhere else and they are supposed to be doing something else. And they no longer have the insight and the judgment because of the disease. For no other reason than the disease, they don't have the ability to understand. Right? So we have to relate to what they're feeling. That feeling as if they're supposed to be somewhere else. That feeling of something isn't right here. And when we relate on an emotional level, it becomes less about the facts and more about what's underneath the facts. And so it could be as simple as, well, we can't leave the house looking like this. We have to get dressed and we have to have something to eat. We didn't even have our tea or coffee, whatever the case may be. We're redirecting them. And we're engaging them in something else. We're making the brain a better offer. Do you see what I mean when I use that phrase, making the brain a better offer? Because right now, all he's thinking about is it's Saturday, it's the Sabbath, I'm supposed to be at temple. Right? We're making the brain, if we just try and engage with that, we're setting ourselves up for failure. Because we're saying, but that's not what day it is, or we already went to shul, it's the afternoon, right? We're engaging with them on a level that they don't have the ability to participate. But if we make the brain a better offer, by getting in another angle, into something that brings them pleasure, we may find that we're more successful. Does that make sense? Is that something you can try to employ? Yeah? I think an example might be, it depends. If the person isn't dressed appropriately to go to shul, you might say, well, we can't go like that. If the person always took a shower before leaving the house and he or she hasn't, then we might say, well, we have to get ready. We can't walk in the neighborhood looking like this. We have to get ready, right? Or if the person always eats in the morning and we didn't eat, or even if we did, and they don't remember that they did, we might say, well, let's have something to eat because it's going to be a while. And now you're at the table and you're having a snack. And you've created an activity that brings them pleasure that has nothing to do with the anxiety they were feeling about them supposed to be being somewhere else. Right? So it's our job to shift that focus onto something else. We're redirecting, we're engaging with them empathically and emotionally about the feeling, not the facts. And we're distracting them with something. We're making the brain a better offer. We're engaging them in something that brings them pleasure and meaning. Yeah. Well, and you're going to have to forgive me because I don't know all of the rituals, and I don't. So if I'm saying something that's inappropriate, let me know. Is there harm in lighting the candles on a day that isn't Friday? Then light the candles. I have to tell you, I'm really glad that the answer was no, because I don't know that I have all the answers for if the answer was yes. But I think so the question is what, I think you know. The question was, if he thinks that it's every night is Friday night and wants to light the candles, some of that has to do with us, right? So what does it mean for us as the caregiver to see somebody we care for, right? Who's been the leader of the family, perhaps, being so confused about what day it is. Someone who took such pride in knowing what they were supposed to do on these different days and all the rituals and leading the family and the prayers and right? It's hard for us to see that person going through these changes. But we need to honor the reality that this person is living in. And if there is no harm in lighting the candles, in saying the prayers, in going to temple as often as the person wants, these are activities that have historically given this person pleasure and meaning, right? I think we have to, there's a real distinction between who is this and why is this important? For whom does this matter? And I think when we ask the question, who cares about some of these issues, the answer is going to be we care. Who's it for? It's going to be for us. Who's it for that they know that it's not Friday? That we don't light the candles today? That we don't do this today? That we don't do that today? That's for us because it means that the person is declining and all of the things that I've just been talking about, right? So if we're able to separate the impact of the changes that we're seeing and recognize that it has more grab, more meaning, more emotional impact for us than it does on this person's well-being, it really sort of, I think, takes away some of the pressure and some of the anxiety that we are bringing to the situation. There's an expression, it takes two to tango. It takes two to tangle, too. So some of this we may be doing. We may be bringing some of the anxiety because of the emotional impact. And that's not blame. Please don't hear that as blame, as we're doing anything wrong. We're doing the best we can. And again, you cannot remove the emotional impact. Seeing someone you care for declining as a result of this disease has real meaning. It has an incredible emotional impact, whether it's your husband or your wife or your partner or your parent. This is not the way that we thought that this was going to go. And we'd be kidding ourselves if we say, just do these changes and everything's going to be better. This is incredibly hard. So we need places to go to deal with some of the emotional impact so that we can free up some of our own space in our head to be able to put some of these things into practice. Taking advantage of the programs, the support that you get from Zicharon is an incredible opportunity. Recognizing that you're not alone. And if you take shame in the fact that someone in your life is dealing with this disease, look around the room. This is not affecting one person. This is affecting the entire community. Right? So to pretend that we're the only one dealing with this and that no one will understand, I think is a little misleading. And to think that we can do this alone, I mean, there are no words. I cannot emphasize more strongly that you cannot do it alone. No one can do it alone. It's too big. And the impact is profound in every way. Emotionally, physically, financially, spiritually, psychologically. It is too big. If you are thinking you have to do it alone, out of guilt, out of love, out of fill in the blank, you're being unreasonable to yourself. Does that make sense? I'm giving you permission to accept that no one in this room can do it alone. No one out there who is afraid to come tonight can do it alone. I don't care how much money you have, how much love you have, how much guilt you have, how much faith you have, how much patience you have. It doesn't matter. I mean, think about what we're talking about. We're kidding ourselves if we think that this is manageable, that we can carry the weight of this, that we should, that we must, that we're supposed to. There's no way. So I'm giving you permission to be open to help, to find a way to ask for help. There's no shame in asking for help. It's hard, right? And again, I'm planting seeds. I recognize you're not going to go home and all pick up the phone tonight and call the 24-hour helpline and say, Matt said ask for help, so here I am. But think, if there's one thing that you take away tonight, it's this last part we're just talking about. You have to learn how to do it, and you have to have a place. So if you think about your brains, how full they are with the anxiety and the stress and the burden and the fear and the love and all of that, the guilt and the everything, you almost don't have room. You know that expression bandwidth that the kids all use today? We don't have enough space in our head to take in all of these strategies. We need a place to put the weight of what we're dealing with, so that we actually create additional space to be able to take in what I'm telling you, to take in the support from one another, from Leah. We need to be able to deal with the emotional impact, to allow for some of the skills to be developed. Right? Does that make sense? So if there's anything that you leave here with, that's what I hope it is. That's really what I hope it is that you recognize how many people are here to help. And when you talk to people who are going through it, it's like nothing else. This disease, I don't have to tell you, it's so isolating. It's isolating for the person with it, right? Because he or she often withdraws. They tend to say, well, they withdraw from activities that have historically brought them pleasure. You go, I'm going to stay home, I'm fine, I don't want to, leave me here. It's just as isolating for the caregivers. We isolate ourselves in a lot of ways because we don't know how to talk about it with people. We don't know what to do if the person does something that's out of the ordinary, how to react to it, how other people will react to it. Our friends don't know how to be supportive. They don't know how to communicate with somebody with the illness. They don't know how to talk to you about what you're going through. But when we talk to people who have lived through it, who are living through it right now, when you lean on each other and you talk and you see people nodding, it changes everything. We're talking about relating emotionally, right? I mean, I know that I'm onto something, and why I'm going, diverging from this presentation I put together is because as I'm saying these things, I see you nodding. So I know you get exactly what I'm talking about. I know that I'm striking a nerve with this part here. The power of seeing someone nod and say, I get it, because I'm going through it too, there's nothing that compares to that. Because we feel alone. And sometimes we create that. We do it to ourselves. But if we let some of those barriers to assistance, barriers to just being open about what we're going through, if we let some of those fall, I think we start to see how common this is. These diseases know no bounds. No race, no ethnicity, no socioeconomic, no religion. We are all at risk. We are all going through it. And as the stigma continues to be reduced, these are opportunities for us to talk to other people who are living what we are living and going through what we're going through, learning from each other and getting the support from each other. That's the only way to get through this. We can't do it alone. So if some of these strategies that you're trying aren't working, and you may remember this from the other times I've been here, stop. If their anxiety is escalating, and you find you don't know what to do, 2 words that are magical with Alzheimer's disease. I'm sorry. It just diffuses things. It can take all the sort of energy, that negative energy that's come up because of whatever's going on, and it takes it away. And I might literally take a step back. That retreat, that body language can be really helpful. I might say, I'm so sorry. I upset you. Let's relax, right? I'm going to stop. I'm not going to keep going. I'm not going to forge ahead. There's no point in doing that. And then I would leave the room, right? And I might come back in 10 minutes or 15 minutes and try something else. Maybe I'll leave the room and go get chocolate if I know that that's something that this person responds to. Maybe I'll leave the room and go put on some calming, soothing music, right? Don't argue. Do not use our world. Don't use reality orientation. It doesn't matter, right? Who's it for? That's the question that I hope that you'll begin to incorporate. You know, and this is what I'm thinking we need to do. I'm thinking we need to get up and get dressed and look our best every single day. Got to get this person up and out and going and take a shower every morning because that was very important to him, to be clean and presentable every day. Who's that for now? It might be for us. If it's for us, then maybe we need to reevaluate how important it is. If it's for them, around their safety, their quality of life, their well-being, then we need to figure out another way to do it. But quizzing people, asking them if they remember this, if they know who that is, if they remember what they had for breakfast, that's for us usually, because it means it's not as bad as we thought it was. Maybe they're getting better. Maybe Dr. Greenberg wasn't telling the truth when he said that the medications don't slow down the progression of the disease. That's all our stuff. And we need to recognize that. Because when we recognize that and we're able to separate who's this for, if it's for us or if it's for the person with the illness, that changes the way we're going to begin to work with them or continue to work with them to engage more meaningfully. Yes?
So, I've had this amazing relationship with my dad my whole life, but now it's getting really difficult. And when the moment comes where he's doing something that's not safe, and I try to distract him to do something else, and he's very insistent, and I don't want to lock horns with him, and I want to win his cooperation. How do I go about doing that?
Yeah, so the question was, when my father wants to do something that isn't safe, he becomes insistent despite her best efforts in trying to distract him. You know, I think safety is really paramount. That's not for us. That is for them. And I think that it's going to depend upon what it is that's going to be your tool. I mean, there's so many, it's unique to your situation and him. But I think employing some of the tactics and the techniques that we've described, and again, we're talking about safety, which is a very wide category. It can be so many different things that are unsafe for this person. But we're going to have to try to create an environment where that unsafe behavior perhaps is avoidable from the onset, so that we're never creating. Can you give me one example of safety issue?
So one example is he needs to go somewhere right now. There's not a person available right this minute to do what he wants to do. I want to accommodate him. I want to.
Like an errand, like I need to go to the store, and he wants to leave, and he says, I don't need anybody with me, I'm just going.
And if you're not going to take me right now because I need to go right now, then I'm going to hitch a ride.
I think what I might do, so if you try and get in there and try and convince him that he doesn't need to go right now, or let's wait 5 minutes and maybe I'll be able to find someone, that's engaging with the facts, right? So I might engage with the feeling, which might be, you seem really stressed. What are you doing? What do you have to do right now? I might step into his world, try and get a sense of what the urgency is about. What is happening in his mind where he's feeling that this is something that has to happen now, and I might try and react or engage with him on that emotional level. So more about the feeling that he's bringing about than the errand that he's trying to run. Because if you just try and, right, so he's got it in his head that this is something I need to do right now, whether you're coming with me or not. Trying to get him not to do that thing is dragging him into our world. That's your, in a sense, arguing. Because you're dealing with facts and logic and reason, right? Which he's not able to do. So what we have to do is figure out, well, what's going on? What's happening for him that this is something he's feeling anxious about having to do right now? You know, Dad, you seem really anxious about making this errand. Tell him, you know, and try to get him into a conversation around that, which takes it away from leaving the house right away. There are other strategies that we can, and again, having more information might be helpful. But I think in the interest of time, I do need to move forward. I can tell you right now, we're not going to get to all the slides that I put together, and that's okay. That's okay. These are really big topics that we're talking about, and I mentioned at the beginning, an hour or 45 minutes, we're really just scratching the surface. So again, my hope is that I'm getting you to, hoping that you're starting to look at this a little bit differently. It's not 180 degrees from the way that we've been dealing with this person. It just might be a slight shift in your perspective, in your approach that you're going to find to be really helpful. I'm sorry, I'm not going to be able to take questions today because there's still some information that I want to share, and I do only have about 7 minutes. So these are common causes of some of the behavioral changes. Oh, behavior equals communication, and we actually heard this with Dr. Rosenberg, right? Or Greenberg, Bob Greenberg. I keep saying Rosenberg. Nobody corrected me. Oh, it's Greenberg. Yeah, wasn't I saying Rosenberg? You're so nice. Nobody even told me I was saying... Did I say that when he was here? I said it wrong when I was here and you let me... I didn't? Oh, okay. I did. All right, I only have now 6 minutes. This isn't what we need to talk about. Behavior is communication. The doctor talked about this, right? Behavior, people acting in ways that are attempting to communicate an unmet need. Rather than focusing on what they're doing, we need to explore why they're doing it. Too often people say, how do I get this person to stop doing this? That's the wrong question. The question you need to be asking is, why are they doing it? Why is she banging on the table? Why is he yelling and screaming right now? Not, how do I get him to stop yelling and screaming? What's underneath the behavior? So these are some of the more common causes of behavioral challenges. These are big, wide topics too. It can be communication, which is a lot of what we talked about. Either they're not understanding us, we are frustrated that we're not understanding them, right? It could be physical, they could be in pain. It could be emotional, they might be anxious or scared. It might be related to the environment. Perhaps the lights are too bright or it's too cold in the room. And it could be related to the task. We're asking them to do something that's too complicated. They can't follow what we're asking them to do. Or maybe we're asking them to do something too simple, right? And they feel like you're infantilizing them or treating them like a child. These are some of the common causes of the behaviors that we see. And then... Thank you. So again, I just put some of the common issues to be thinking about in each of these categories here. So knowing who this person is going to be really helpful to understanding how to anticipate their needs and to understand what their behavior might mean and how to get in there, make the brain a better offer. And I put this little graphic in here because we need to be sort of detectives. It's not enough to say, what is she doing? What is he doing? We need to figure out why. And the more we know who this person is, the more tools we have to make the brain a better offer, as we've discussed already. So what the person is doing as opposed to why they're doing it. And there are responses to these behavior challenges have to be person-centered. And that means they need to be about the unique individual who is sitting right in front of us. And we can't employ person-centered interventions unless we know the person really well. Make the brain a better offer. So I put up here, I just put 2 behavior intervention strategies up here. So the trigger might be bathing, right? And it can be related to a lot of things. We know that most people in the middle stage of the disease become resistant to personal care. The bath can feel very scary to people, especially Holocaust survivors. We know the response might be a refusal to bathe. It might be a real display of anxiety and fear. It could be crying or screaming because it can represent negative memories from their past. So our approach is key, right? If we look at how we can modify the bathroom experience for someone by creating, and again, I sort of covered this already actually, by creating a different kind of experience around bathing, maybe we're able to manage it in a way that's more successful. If we don't use the language that tends to be a trigger for that kind of behavioral response, and we just say, let's get clean, let's clean ourselves up. And again, that may not be the language that works for the person you're caring for, but just to get you to start to think about how we can think more creatively in our approach. Maybe the person doesn't require a bath or a shower in the bathroom, in the shower. Maybe there are different ways that we can clean someone without subjecting them to an experience that might be very, very stressful and anxiety-provoking for them. And again, if what we're trying is still resulting in some of these responses that I put up here, what do? Stop. I'm sorry. And we try again later, right? Because if we think, well, this has to happen now, maybe that's for us. And that's less about the benefit of the individual. Certain recorded music can be triggers for people, right? So they might react with anxiety or a refusal to listen, right? Or they may become anxious, they may get up and try to leave, right? So we want to be mindful of the impact of different kinds of music on different people. Knowing the kinds of things that can provide them with a soothing, calming environment. There are different kinds of music that the person may respond to. Perhaps it's songs, religious songs even, that the person has always enjoyed, that you can sing together, right? Singing together with somebody is an activity. Praying is an activity, right? Don't think of activity as something that means we gotta, spend 5 hours figuring out a plan and then putting that plan in place. Lighting the candles, to use the example before, can be a really meaningful activity. Tell me a story about, fill in the blank, can be an activity. A memory that has a real positive relationship to the person, that it brings about really positive, warm, happy experiences and times, might be an opportunity for you to engage them in storytelling and reminiscence that's positive, where even if you've heard the story before, creating an environment where it's about their quality of life, right? That you can allow them to tell a story that is very happy for them, whether it's any kind of memory that it may be. So again, it's about shifting your perspective. So consider that some sadness is okay. If we're trying to be 100% happy 100% of the time, I don't know anyone that lives like that. I mean, it's an impossibly high bar that we're setting for ourselves. Prepare for questions about people who are no longer living. People often ask for their mother or their father or their spouse who's passed away. We don't want to re-traumatize the person by every time they ask, we tell them that that person has died. Because somebody with memory loss is going to be hearing it for the first time every time. And we may be bringing about an ongoing traumatic experience. So what we might want to do is say, well, she's not with us right now. Why don't you tell me about her? Tell me your favorite memory about her, right? So it's relating about the emotion. I miss her too. I wish she was here with us right now, but let's make the brain a better offer so it's less about where is she, where is he, and more about an opportunity to talk about positive aspects of that person without subjecting that person to reliving the loss over and over again. Is that something you might be able to, yeah? Okay. Prepare for statements about the environment, that people are going to be talking about wanting to go home when they are home. But if I say, you are home, these are your books, this is your stuff, we've lived here for how long? I'm dragging them into my world, into our world, right? I want to focus more on what home means. Well, tell me about your home. What does your house look like? What's your favorite memory about your home? Which is your favorite room in the home? Right? So we're engaging them less about the facts and more about what's underneath all of that. Being mindful about secondary traumatization. And what that means is for you. So sometimes people are recounting stories that perhaps are very, very scary and unsettling. Perhaps if somebody was a Holocaust survivor, they're sharing stories with you that you've never even heard before. Because oftentimes people have shielded us from these kinds of very traumatic, very sad, horrific events. It can be very, very scary for us to be hearing these kinds of stories. We need to be mindful of the impact on us that these types of stories have, and figure out ways to get the kinds of support that we need so that we can cope with the information that we're getting without suffering from secondary traumatization. Is what always true? Are the stories always true, she asked. You know, not always. People often will make up stories to fill in memory gaps. That's common because when we ask them, oh, tell me about a time when, or what, and it often happens with, what did you do last night? Or, you know, do you remember when we quiz people, which is sort of the way we don't want to go, right? They don't know, and they're not going to say, well, I don't know. So let's say, oh, well, I don't know what they'll say. They don't know what they'll say, perhaps. So they might make things up. That's a very good point. And recognizing, too, that there is life after diagnosis. I think sometimes we can feel very hopeless when we talk about a progressive degenerative disease for which there really is no meaningful disease-modifying treatment. When we see somebody exhibiting symptoms or we get a diagnosis, it can feel like there's nothing that we can do. But my hope is that everything we've talked about already tonight, you recognize as things that you can do. The person with the disease still has opportunities to have a very high quality of life. And if we are able to bring about a shift in our perspective and create more opportunities for meaningful engagement and opportunities for enjoyment and pleasure, recognizing that there may be moments of sadness interspersed and difficulties interspersed, and times where we mess up and we lose our patience and we argue and we deal with the facts and the reality, right? Again, we're human beings, we need to forgive ourselves. But there are absolutely opportunities, whatever stage the person is in, for you to connect in a meaningful way. Music, I talked a little bit about music. So music transcends dementia in so many cases. We may find that the person, even in the late stage of the disease, where they seem like they're asleep more than they're awake, their eyes are closed, maybe they're bedbound and nonverbal, and we think, well, maybe there isn't really cognitive activity going on. It's harder for us to engage with them, to sort of bring them out, if you will. Putting on music that this person has historically enjoyed, any kind of music, secular music, prayer, religious music, whatever it is, you may be amazed. The power of music can be so profound. And even things like scent and touch, just like sound and music, has opportunities. Those multisensory approaches can be very, very appealing and calming for people. So I mentioned earlier, if there was a perfume that she always wore, or that her mother always wore, or that his mother always wore, that brings about a sense of calm, right, and a sense of comfort. Maybe you don't just spray it in the bathroom when you're trying to get the person to allow you to give them a shower, but maybe you spray that in the room, right? Maybe we use calm voices. It's all about bringing about that sense of comfort. Not waiting for there to be these other negative emotions coming out, but fostering a sense of comfort. And lastly here, maintaining good dementia care really relies on the exercise of choice, the use of the person's current abilities, so we need to understand where they are within the spectrum of the disease so that we're asking them to engage with us in ways that they can be successful. It all has to do with relationship, and the key to relationship is in this shift in perspective. It's in our ability to change the way that we are attempting to engage this person, and it has to do with their choice, their preferences, their historic preferences, knowing who they are. And the expression of feelings, right? And that's really what it's about too. Because when we recognize what's underneath the facts, what's underneath the information transfer, and we really focus on what the feeling is, that's how we get at what they're trying to communicate. What's the real issue? So it's less about what they're doing and more about why they're doing it. So I hope that you'll take advantage of the programs and services that we provide. We do have a 24-hour helpline. It's available 24 hours a day, 7 days a week, 365 days a year in 200 languages. We have people working around the clock so that 99% of the time you will reach a person, which this day and age is sort of rare, right? You will usually reach a human being. If you don't, it's probably because everyone's on the phone with someone else. But if you leave a message, we call you back as quickly as we can. You don't have to give us your name if you don't want to. If there's shame that you're feeling and I tried to give you the permission to be willing to ask for help, if it's still really hard for you, we don't need your name. We don't need your address and your phone number and identifying information. Say, don't ask me those questions, just answer my question, and we'll do it. We'll do it. The most important thing is that you call, is that you take advantage of the help and the support that we have. All of our programs and services are free of charge. And continue to take advantage of the great programs and services and resources of Zicharon. They're a great partner of ours. We're so proud to have such a strong relationship, to be able to provide you with this kind of information. But again, recognize that we just scratched the surface here tonight. There's so much more depth and breadth in what we're doing. And if we really want to change the way we're providing care and engaging with people, it's going to take a lot more than the hour that we've spent tonight talking about this. So we need to make an investment in our ability to enhance our knowledge and our skills to be able to make these shifts in perspective that I'm asking you or challenging you to do. But I think that if we do it together, we can figure this out. And if we stick together as a community and support one another through these challenges, then there isn't anything that we can't get through together. We need to rely on each other the way that we always do and the way we always have. This is no different. This issue is no different. So thank you so much. I'm sorry that we don't have more time. I really appreciate you staying so late.
When are you coming back?
I will come back, I promise.
Good.
Tell your friends.
Thank you, Matt. Thank you again. Thank you, everyone, for coming. We want to thank Mrs. Horowitz for putting together this amazing program. And lastly, but definitely not least, Mr. Brachia Shuk for founding and funding the organization from A to Z. Thank you.
What's the name?
It's American Alzheimer's Association.
That's different from the AMA.
AMA. I'm the lobby to have their brochures.